Okay, hey guys, I'm back with the new video. I'm extremely sorry. And again, due to some health issues, I've not been able to, make a recording and post the video. So I will post one today and one tomorrow and finish with the updates so that I can discuss in detail about these WHO updates in the lymphoid neoplasm in detail from the next week. So there I'll cover the mismatch that there was of 2 weeks in between. The myeloid neoplasm thing has also come out. That also after finishing lymphoid I'll do that is next to next week. Quickly this time I'll discuss things quickly. I won't take too much time, and after that we are going to discuss the ICC, and then again we can start rotating in between hemat and histo. So let's move ahead. This is the article. So we had done B. Now we are coming to T and NK cell, and then the last part of it. Quickly, T and NK cell neoplasm. Remember, in B, precursor B lesions were added. Like the entire family of Castleman's was added, then proliferative lymphoid hyperplasias of B cell origin, they were added. Similarly, in T, those conditions which you did not consider malignant before, yeah, even in I never thought of Kikuchi Fujimoto having any malignant potential. Now they have added it into tumor-like lesion with T cell predominance. Yes, Kikuchi Fujimoto might look to some like a lymphoma or some sort, but I had never thought of it as a pre-malignant lesion. Indolent T lymphoblastic proliferation, yes, and ALPS definitely 110% yes. Autoimmune lymphoproliferative syndrome, very common, not very commonly, but yes, I had seen this entity in when I was working in a pediatric setup in one or two cases. Considering that I have not come across it, maybe that's my exposure in adults. So yes, ALPS, I was always of the opinion, although I am no one to have that kind of an opinion because I'm not like the great sitting and making the WHO blue book. But I always had this opinion that ALPS should be included in pre-malignant lesions. All those undefined gray zone lymphoid hyperplasias where we are not able to make a diagnosis should be clubbed into gray zone. So the only surprise here for me is Kikuchi Fujimoto. And as we discuss in detail this paper, which I think the WHO Blue Book soft copy is out, I'll just check and upload the link if it is there on my YouTube post page. I'll do that. So probably they'll give you an explanation why Kikuchi Fujimoto has been included. So these three are just like the precursor B cell lesions, which were tumor-like lesions which were not there before. But and the catch is that since it's T and NK cells, so there is T cell predominance. Precursor T neoplasms, so T lymphoblastic leukemia lymphoma, NOS, which was initially just leukemia and lymphoma. Over here you can see, and then ETPL, early T cell precursor lymphoblastic leukemia slash lymphoma has been added. All right, and this NK lymphoblastic leukemia lymphoma, this entity has been deleted. So now you are coming to an entity which has been deleted in T cell. In B cell, I told you hairy cell variant and pro-lymphocytic leukemia. These two entities have been merged with something known as splenic, I think large cell B lymphoma with prominent nucleus or something like that, right? So keep this in mind. NK lymphoblastic leukemia lymphoma has been deleted. So that was precursor, then mature T cell lesion, TPLL remains the same. TLGL, granular lymphocytic leukemia remains the same. NK-LGL leukemia has become chronic lymphoproliferative disorder of NK cells. Okay, chronic, the NK-LGL, the NK lymphoblastic leukemia has been deleted, and the NK large granular lymphocytic leukemia has now become CLPD of NK cells. Okay, then Cesari, aggressive, all this remains the same. Primary cutaneous, just like mantle cell में cutaneous lesions have gained a separate prominence. Similarly, primary cutaneous acral CD8 positive lymphoproliferative disorder has now become primary cutaneous acral CD-positive T cell lymphoma. So instead of just labeling it as a lymphoproliferative disorder, they have called it a T cell lymphoma. That's mycosis fungoides. It was there before cutaneous CD30 positive T cell. It was there as lymphoproliferative disorder, not T cell lymphoma. Cutaneous anaplastic large cell lymphoma, subcutaneous paniculitis, cutaneous gamma delta lymphomas, CD8 positive aggressive epidermotrophic lymphomas were there, and the PCTL, that is peripheral T cell lymphoma primary cutaneous, PCTL-NOS, has been added, which was not there. So you see cutaneous lymphomas in mantle area as well as over here in T cell have been given special importance. Okay. Then intestinal TK, initially known as indolent T cell lymphoma of the GI, has now been called indolent T cell lymphoproliferative disorder of the GI. So the lymphoma and lymphoproliferative disorder is the same thing as autoimmune ALPS, lymphoproliferative syndrome. It is clonal yet not a full-blown malignancy. Having said that, I don't want to create any confusion. It is a malignancy, of course. It is becoming a lymphoma, but frank lymphoma, एक होता है NHL, DLBCL, marginal zone, CLL, और एक होता है category of lymphoproliferative disorders, means might have an autoimmune aspect to it. Although again, it is an overlap. ALL, CLL, CLL में भी autoimmune हो जाता है, ALL में भी हो जाता है, Hodgkin's में भी you get autoimmune. So what is important over here is that a frank lymphoma, instead of just calling it like a frank lymphoma, it is indolent T cell lymphoproliferative disorder of the GI tract. So it's not like a frank lymphoma, but the clinical features are the same. Maybe, I am not sure, I'll read the article, we'll discuss it in the future lectures. The prognosis changes. Maybe some investigative features have changed, considering that lymphoproliferative disorder is a gamut of multiple things like a lymphoma with an autoimmune disorder or just a clonal hyperplasia of the lymphoid cells. I'll have to read this in detail, but that is what I can gauge from the change in the wordings. Then previously indolent NK cell lymphoproliferative disorder of the GI was not included, so they divided T and NK. Initials of T was there. Rest EATL, monomorphic epitheliotropic intestinal T cell lymphomas, NOS, hepatosplenic T cell lymphomas, anaplastic T cell lymphomas were there. Now initially anaplastic was ALK positive and ALK negative. Now that positive and negative has gone behind. So probably the reason is, I don't know, why they switched. Could be prognosis, uh, or the number of, I'll have to read. Maybe there's an overlap between the prognosis of ALK positive and ALK negative. So I'll have to read why they have changed the position. What I understand by this is कि ये ALK को बहुत ज़्यादा prominence नहीं दे रहे हैं. It is an anaplastic large cell lymphoma categorized in T cell lesions, which is either ALK positive. Instead of calling it an ALK predominant kind of a lesion. Again, this is my conjecture. I'll have to read why, what change does this shift mean. Sometimes I feel WHO just shifts names because the makers are divided upon what to name it. This is what I feel. Because I don't see any sense in just shifting the position of ALK until unless there's some molecular implication to it. Let us see. Then, of course, nodal T follicular helper cell lymphomas, the nodal TFH cell lymphoma, angioimmunoblastic type is angioimmunoblastic T cell lymphoma. Nodal TFH CL lymphoma follicular type is follicular T cell lymphoma. Nodal TFH NOS is nodal peripheral T cell lymphoma. Then peripheral T cell lymphoma not otherwise specified is same. So all those nodal TFH टाइप करके जो दिया था ना, अब वो टाइप उसका एक्चुअल नाम बन गया है. And EBV positive nodal T and NK were not included previously. It is included now. Extranodal NK T cell has become NK T cell lymphoma nasal type. Then EBV positive NK T cell and EBV positive T and NK cell lymphoid proliferation or lymphomas of childhood. These hydroa vacciniform lymphoproliferative disorder has a like added now, so not exactly hydroa vacciniform. Then systemic chronic EBV, they've just shuffled the words is what I feel. Sitting there, they shouldn't be saying this, nothing much to do. and they had to come out with a new edition. So systemic chronic active EBV, the chronic and the active stays, they define that it is T and NK cell type. Okay. Severe mosquito bite remains the same, and Hydroa vacciniform is not Hydroa vacciniform, it is Hydroa vacciniform like. Extra nodal NKT, they have added something and like nasal type. Okay. So again, this is a summary. In short, lymphoma mimics included to help differentiate lymphomas, which should have been done long time ago. ETV6 Ranax1 like BLL added. Nomenclature changed to suit the molecular events. PH like AL is an entity now. We used to read about it, but it was not a separate entity. BPLL is removed. CLL essentially flow markers define it. Richter's transformation word is used instead of syndrome. SBLP, and I've told you about when we do other the immuno paraproteinemias, non-Waldenstrom's type LPL has been defined. Follicular lymphoma has been classified as classical and uncommon, and the grading has become redundant, although still used. Then 3B is become FLBL 13, DLBCL, GCB type, and AV are redundant but retained. Double hit lymphomas renamed as DLBCL, high grade B cell, MIC or BCL2 mutated. BCL6 हट गया है, BCL6 is no longer hit, ठीक है, and triple hit lymphomas are improved. That it makes sense. It must be having some prognostic implication. Burkitt's lymphoma, like lymphoma with 11q, renamed as high grade B lymphoma. Morphologically resembles Burkitt, not molecular, maybe not clinically. We'll discuss that. Then some very immune rich sites developing lymphoma like vitreoretinal eyes, DLBCL, and testicular DLBCL have been added. Then I'm happy that the term gray zone lymphoma is back, although not many people will be happy. Why? Every time you can't put a lymphoma in a specific bracket. Just because it is showing part of one marker and not, there has to be an overlap. Because I believe lymphoma is a transformative disease. Lymph node is already a site where you get a lot of immature cells. In you and me also. If I'm having a viral infection, you will see a lot of reactive cells, you'll see large germinal centers, etc. So it is a transformative lymphoma. So today you are calling something as one type of, or maybe a low grade B cell, it becomes a high grade B cell next time. The treatment then goes, and sometimes there are morphological overlaps. You get some nodules, etc., in some lymphomas, and then you think, okay, follicular क्यों नहीं है? So yes, there is a gray zone. We should accept there's a gray zone. It is difficult to eliminate that gray zone, especially in countries like India, where you can't perform molecular everywhere, and then you label something कि ये molecular कराओ तभी ये diagnosis बनेगी. All that makes it a problem. At least when we tell them, the clinician, at least in our resource limited setups, that this lymphoma I am not able to categorize into either. I have come across cases where out of say a panel of 15 markers, only one is positive. So now based on that one, I have to label it as something because the word gray zone was not there. So at least even if I'm labeling it as something, I can put a note. So the clinician knows that if they are giving a specific targeted therapy, it might not give you 100% recovery. There are some gray zones in it. So I'm happy that it is back, although some people might not be happy. Non-mediastinal gray zones will, however, be called DLBCL, but mediastinal, you have that liberty of calling it as a gray zone lymphoma. Burkitt's classified as EBV positive negative. You know, EBV was out there in Burkitt's for a long time, so good. And classical Hodgkin's lymphoma subtypes are redundant yet retained. NLPHL needs to be renamed as NLPVL, but still under trials. Then these medical renal disease and autoimmune disease and TEMPI and ASOP सब add हुए हैं, and we'll discuss about them. These are new terms, medical syndromes. Then TNHL mimics, that is I told you, ITLP, Kikuchi and ALPS, NK lymphoblastic leukemia removed, NKCLPD renamed as NKLG. No. Okay, I was wrong. It is actually the chronic lymphoproliferative disorder which has been named as NKLGL. CTCL subcategories made separate entities. These we'll discuss, so I'm not going into detail. Extranodal NK T cell lymphoma, nasal dropped. DUSP22 is no longer considered favorable. Initially, remember, it was favorable in ALK negative, so now it is not. And ALCL has 3 subcategories. So thank you. Again, tomorrow I'll be uploading the second video and finishing in short with the article so that we can discuss each entity separately in detail. Then, and that too, I'll upload frequently next week, so that we finish with this. Then we do the myeloid article in 1 week, and then we do the ICC. After that, we can go back to a normal cycle. So thank you so much, and I hope you like it, and please share with your friends, because this is important.